In this presentation, we'll talk more specifically about the types of outcomes that are available. So once you've thought through the general questions and you've selected an outcome, we need to really consider what are the standard types of endpoints? Is it a composite outcome? Is it a surrogate outcome? And what are the common classes of outcomes? So you'll hear a lot of terms when you get into clinical trials, and we'll cover a few of those that are common for clinical trial outcomes. Your best friend is always a search engine. If you hear somebody say a term that you don't know, just go ahead and look it up, and it may be something that is just new to you or new for that specific disease population. So what are the common types? There are three common types of measures that you already know from your statistics courses. Continuous measures, those are numbers or counts. Categorical measures, those are things that are collected in categories or in name. So binary, nominal, ordinal, and counts. So you'll notice counts is there twice. And depending upon how you analyze it, counts can be a group or it can be treated more as a continuous measure. It really depends upon the specific endpoint. And this is where you really need an expert statistician involved with your planning so that you know how to approach the analysis. And then time to event. So this is assessment of an event and the time it takes for it to happen. And this is a combination of categorical and continuous. Because the event is categorical, it's a discrete measurable event, something either did or did not happen. And then you're measuring the continuous time from either baseline or the prior event to this current event. And that's a continuous measure. So we've heard that analysis follows design. When you choose a continuous endpoint, you're generally looking to compare means or medians. If you have a categorical endpoint, you're looking to compare proportions. If you have time to event, you're looking at comparing the median time to that event. And this is a very basic nature for unadjusted analyses. Once you move into covariate adjusted, so if you're adjusting for things like age or gender, there are then analogous analytical methods associated with each of our basic methodologies. Let's quickly review a few of those. So for continuous endpoints that are collected as a number, the mean or median response is appropriate. Remember, means are considered to go with symmetric or normal distributions, whereas medians are more appropriate if it's something that is skewed or not symmetric. Counts are generally not analyzed as a continuous measure unless you meet very specific criteria. You have to have a lot of data. It needs to look somewhat symmetric. A number of count metrics are very skewed, and so treating it as a continuous measure is not really appropriate, particularly if you think about counting something like a heart attack. 2.3 heart attacks doesn't make sense. You'd want to report or look at the proportion of people that had one heart attack, two heart attacks, or what is the likelihood that someone would have 2 heart attacks in 3 years. Our analysis, when you have a true continuous outcome, will compare the mean or median between groups or the mean or median change between groups. The simplest analysis here is a t-test for 2 groups, so basically a pre-post test. So we have the baseline measure, we have the post-intervention measure, we create a difference, we compare that difference to 0 to see if the difference is changed. When you move into 3 or more groups, or if you have combinations therapies, if you're looking at factorial ANOVAs, then you would use an ANOVA. If you have covariates, it would be an ANCOVA. If you have multiple time points, you would be looking at a repeated measures or mixed models with 3 or more time points. When you're looking at continuous outcomes, you're generally looking at a linear model, but there are plenty of options for nonlinear and other distributions when you're looking at median comparisons or if you want to get into the assessment of counts. For the categorical methods, these endpoints are collected as a discrete group. So as you think about it, somebody is either a current smoker or not a current smoker. You may have definitions, so it may be less than 100 cigarettes in a lifetime. It makes them a non-smoker. Nominal means there's no inherent order, so think about Republican or Democrat. Ordinal means that there is an inherent order, so low, medium, high. Ordinal generally means that each participant could have been observed in every level. So they could have started out at a low response and then moved their way up to a high response. It's just that you only captured them having a high response, or that you have assigned an inherent order, that one outcome is better than the other. It's important to remember that if you only have two response options, so if it's binary or dichotomous, then nominal and ordinal will give you the same results. Counts are generally considered discrete events like relapses or lesions. Depending upon the distribution of your counts, it's almost always treated as categorical, or at least it should be. The analysis here will compare the proportions between the groups. If you don't have any covariates, it's a simple chi-square or a Fisher's exact test. If you have covariates, you're getting into logistic models. If you have repeated events, it's McNemar's, which is very simple, or a GEE, generalized estimating equations with covariates. GEE takes a lot of statistical savvy, so please make sure if you're planning on repeated events, again, that you contact and work closely with a statistician that has expertise in that area. Counts, you're usually looking at Poisson or negative binomial, or you could simply be looking at the proportion of people with each count. It just depends on how many counts you have. When you're thinking about time to event, also called survival analysis, the assessment of an event and the time it takes it to happen. So again, a combination of categorical and continuous. Events need to be discrete and measurable. You may have to have an adjudication committee for something like a specific type of stroke. So you may not know at the exact moment whether or not your endpoint has been met, but you would collect it as if it had. And then when the adjudication committee looks at scans and all available data, they will determine whether or not the event occurred. Timescale should be appropriate to the disease and the event. So if you're looking at halting progression in multiple sclerosis, you need to be studying people for multiple years. The definition of progression at the very lowest end is a 6-month outcome, and that's 6 months sustained, which means you usually have to be watching them for 3 months longer than that to make sure they don't go back down. And if you're looking at true progression into secondary progressive multiple sclerosis, that's going to take multiple years to really assess. Whereas if you're working in preemies, your time scale could be hours, minutes, days, weeks, and that would be appropriate to the event. Analysis for these will compare median time to the event or time between the events. Survival analysis times are generally very skewed. Remember, they can include censoring. That means that you follow someone for a period of time, but you never actually observe the event. So you end up getting these long tails on your distributions. Consequently, you will start with a non-parametric analysis. So the unadjusted group comparisons would be done by Kaplan-Meier. Once you want to add in covariates, so in addition to your treatment group, you want to adjust for age or disease duration, then you're looking at something called a Cox proportional hazards models. Cox proportional hazards models allow for repeated events as well as allowing for time-varying covariates. So if there's something like the blood pressure that is associated with stroke, people's blood pressure changes over time, a Cox proportional model will allow you to have varying blood pressures throughout the course of your study. If everyone has an event, then analysis is basically a comparison of the median time to event. It's very rare for everyone to have an event. But if you expect that everyone will have an event, then you could potentially just be looking at a Wilcoxon test for median time. Often you'll also report the proportions and counts of events too. So what about the special types of outcomes that you'll hear about? Composite outcomes and surrogate outcomes are two of these. Composite outcomes are comprised of 2 or more individual measures. So if you're looking at the difference between systolic and diastolic blood pressure, that's actually a composite outcome. If you are looking at something like the DAS-28 for arthritis, that has physician-observed, laboratory, and also sometimes a patient-reported outcome, that's a composite measure. If you're looking at surrogate outcomes, this is something that is an outcome that's used in place of a biologically definitive or clinically meaningful endpoint that's not easily measured due to time or access. Something to think about with the surrogate outcome is ultimately in long-term chronic illnesses, the ultimate endpoint would be death from that disease. But you obviously generally don't have the money or the time to study every person who has a stroke all the way through to ultimately a death from complications from that stroke, or death from multiple sclerosis, or death from COPD. And sometimes you can't actually measure the death from the disease because people live long enough that they then die of cancer, which would in fact give you a censored outcome. So surrogate outcomes are actually out there in a lot of places. And sometimes it's just that it's very difficult to get to the diagnosis. So if you think about something like CTE, so the concussion-related brain disorder, that can only be definitively diagnosed now with a brain biopsy. So they're looking at finding surrogate outcomes for CTE. If you look at something like endometriosis, it's actually a definitive diagnosis based on pathology. So not a lot of people actually have a surgical diagnosis associated with it, but there are other surrogate outcomes. When considering a composite outcome, does each of the components meet the definition of an outcome? So is each component a validated measure? Is it reproducible, repeatable? How many components are there? The next important question is, what happens if you're missing one of the components? So there's something called the multiple sclerosis functional composite that has 3 separate components. One is the PASAT-3, so it is basically an addition test that the participant does out loud and you count up the number correct. Another one is a 9-hole peg test where you're looking at their hand and cognitive skills, and then the other is a timed 25-foot walk. Then the multiple sclerosis functional composite is actually basically a Z-score. All 3 of those components are put together and are put on the standard normal. So what happens if you're missing one of those components? What happens if someone can't complete them? What happens to your composite score? And then how is the composite interpreted? Are the parts evenly weighted? So if someone's composite score changes, do you know what that actually means for your population at large? And are there some parts of the composite that will change the overall score more than others? So it's important not to just collect the composite measure, but to collect each of the individual components as specifically as you can, because sometimes you may not observe an overall change in the composite, but what you might find is that one of the components of that composite did see significant change. So just be clear on your composite measures about what goes into it, how it's collected, and what it means when there is a change. When thinking about surrogates, if we go back to Piantadosi, a useful surrogate endpoint has the following properties. It can be measured simply and without invasive procedures. It is related to the causal pathway for the definitive endpoint. So this is something that would happen along the way to your definitive endpoint. It yields the same statistical inference as that for the definitive endpoint. So if you were to see a change in the outcome, an improvement in one direction, the surrogate outcome should show improvement in that same direction. And it should be responsive to the effects of the treatment. So true surrogates take a lot of study. They need to be shown to be measuring the true outcome. And there are any number of areas of research into surrogate outcomes in almost every disease domain. Just make sure that you look up and understand the properties of a surrogate outcome that you're using. What other outcome classes do we have? So we looked at hard or soft outcomes, objective or subjective outcomes. We looked at continuous and categorical. We looked at composite and surrogate, and all of those can be one or both of categorical or continuous or a combination. The same thing is true here with outcome classes. So patient-reported outcomes or patient-reported outcome measures, PROs or PROMs, those are when the participant tells you how they're doing. That's a patient-reported outcome. There are clinician or observer outcomes. So that's when the clinician or observer or assessor or trained evaluator is going to determine the outcome. There's the health-related quality of life, so QOLs, quality of life measures. Those are very common in long-term chronic diseases. How are people managing the disease? That rolls right into activities of daily living, so ADLs or IADLs. And there are different activities of daily living depending upon the disease that you're looking at. So you can look those up for your disease-specific area. There are disease-specific outcomes. So the EDSS and multiple sclerosis would not be used, say, in Parkinson's, though there is some overlap in the things that you measure. General health outcomes, so the SF or the short health forms, the PROMIS scales, which are actually part of the patient-reported outcomes, overall fitness levels, so anything that's general health related. It is important to get a general health outcome for your population if you want to compare them to the population at large, or if you want to compare them to prior clinical trials so that you can assess the health of your population in general, not necessarily specific to the overall disease. So when you are selecting an outcome, your endpoint should be, again, measured as specifically as possible, and your outcome will influence the analysis. If you can use continuous measures, you can categorize them later. And then be aware of common metrics that are available to you. Those are well understood and will help you translate the results of your study back to the disease population, the healthcare providers, and the patients.